Hello, everyone. Welcome to our monthly talk. We will talk about the women's health in neurology today. Gender has profound, complex effects across all fields of health and neurology, no exception. Biological differences affect the symptoms and onset and prevalence of multiple neurological diseases, and it is very important to take into account when approaching a patient. Focusing on women's health in neurology is especially important today, as historically, given the culture prejudices and women often excluded from clinical trials, we are learning today prevalence of some neurological disorder multiple times higher in women. Dr. Mary O'Neill is the Director of Women's Neurology Program, as well as the Director of Ambulatory Clinic in Brigham and Women's Hospital and Neurology Department. She is a stellar expert in women's neurology. She has written multiple chapters, papers, and books in the field and created a patient-oriented website for women's neurology. Aside from her clinical duties, she is and was highly involved in teaching during her entire career. She is the Director of Women's Neurology Fellowship in Brigham and Women's Hospital. She organizes CME accredited monthly multi-specialty conference in a variety of aspects of women's neurology. She directs the Neurology of Pregnancy course and also co-directs an obstetrical neurology course at an AAN national meeting every year. She teaches residents and fellows on a daily basis across the variety of specialties. Dr. O'Neill today will talk about the sex-specific concerns. We'll describe the pathophysiology of neurological disorders as it relates to sex and discuss treatment considerations in women. We can't thank enough to Dr. O'Neill for honoring us today and accepting to give us this talk despite her very busy schedule. We will learn a lot from her today, and without further ado, I present Dr. O'Neill.
Okay. Thank you so much for that very kind introduction. It's my honor to speak to you today about women's health in neurology and hopefully give you a different perspective or a different lens to think about neurologic disorders in women. This is a picture of the Connors Center, which houses the majority of women's health here at the Brigham and Women's Hospital in Boston, Massachusetts. I just wanted to let you know I have no disclosures that are pertinent to this talk. I do some consultant work for Crico Malpractice and Teladoc, and I do have received some royalties. So I wanted to sort of start a little bit with a brief history of how this whole women's neurology program came about, because we were the first women's neurology program in the world. So in 1980, 3 Harvard hospitals came together. And so the first was Peter Bent Brigham, which was a medical surgical hospital, depicted a picture there on your left. That was a medical surgical hospital. The Robert Breck Brigham, which was a rheumatologic hospital. And then on your far right is the Boston's Hospital for Women. So at the conception of the hospital, Brigham and Women's Hospital, women's issues were a core mission. Hospital leadership decided that there was be a building to reflect each of their core missions. And so on the left is the Connors Center that houses women's health, and on the right is the most recent building on campus, which is the neurosciences building, which houses rheumatology, orthopedics, and all of neurology and neurosurgery. It was my former chair's idea to marry these two specialties of neurology and obstetrics to form a women's neurology program. So how do I sort of think about neurologic disorders in women? Well, here's sort of a schematic of the life cycle of a woman, and superimposed on that, you have neurologic disorders. And some of these disorders are much more prevalent in women, such as multiple sclerosis and migraine. Others, like epilepsy, have equal prevalence in men and women, but because they affect women in their reproductive years, it's very important to understand how to manage women's aspects of health. And stroke, of course, again, stroke in pregnancy, which we'll talk about, and stroke in older women, each have their own separate issues in management. Then there's neurologic problems that only come on in pregnancy, such as eclampsia and stroke. So what I thought I would do today is talk about some sex-specific disease concerns. And I can't talk about just one disease or disorder because there's multiple. But I'm going to give you some examples to include multiple sclerosis and migraine. We're going to, and stroke and pregnancy, eclampsia, and some stroke risk factors. And then we're going to talk about pathophysiology as it relates to sex and how to choose appropriate treatment for women with neurologic disorders. So in a young woman in the reproductive years, if I have to ask, one of the most important questions to ask that young woman is, are you planning pregnancy, right? And their answer to that question is going to frame how you approach their neurologic disease. And so particularly in this, here in the US, where Roe v. Wade has just gotten overturned, it's really important to think about this family planning because unfortunately many pregnancies are not planned. Another, what you're going to discuss is the medication risks in pregnancy, okay? And you're going to discuss the effect of pregnancy on their underlying disease and the converse, the effect of their underlying disease on their pregnancy. So all of these things are important to discuss with young women. Well, we've moved away from these FDA pregnancy categories and we're supposed to talk about risk and benefit. And I think that's good, although I have to say these old categories at least give you a framework of where to start because it's really hard to just take a medicine, say with the risks and benefits and go through it. So I think at least it gives you a framework to start and then you can refine your thinking further. Now, I want to just make a couple of points about these FDA categories. So category A, where there's adequate, well-controlled human studies, no risk to baby in any trimester of pregnancy, it's a bit of a fairy tale because for the most part, pregnancy is an exclusionary criteria for most clinical trials. The exception to this, of course, is magnesium. Second point I wanted to make is we're trained that a category B would be better than a category C. Well, it's the categorization or the risk benefit is based on the knowledge that we have. So for example, clopidogrel, the antiplatelet agent, is a category B, whereas aspirin is a category C. Yet our maternal fetal medicine colleagues have a huge amount of experience and feel very used to using low-dose aspirin as a preventative for pre-eclampsia. The next thing is you have, when you're prescribing a medicine, the question you have to ask yourself is, what is the reason I'm prescribing it? Because that's going to change how the risk-benefit ratio. So for example, let's say I have a young woman with refractory epilepsy. And the only medication, the only anti-seizure medicine that works for her is valproate. Well, that valproate is a category D. If I take that another patient and I'm using valproate for migraine, which is a much more benign condition, it becomes a category X. And the last point I wanted to make about this is not only do you have to think about what the reason you're prescribing the medicine is, you have to think about where the woman is in pregnancy. So what trimester? So medicines can change class by trimester. So for example, non-steroidals often are avoided in the first trimester because of concern about pregnancy loss. In the second trimester, they're actually category B. But in the third trimester, because of they can cause premature closure of the patent ductus arteriosus, they become a category D. Okay, so what I thought I would do is I'd use some examples of different neurologic disorders and sort of frame how to think about them. And again, each of these is a lecture to itself. But I just wanted to kind of give you an overview because you're going to be seeing these women no matter who you are. If you're an internist, a family practitioner, an emergency room doctor, you're going to be seeing women with these conditions. So let's start with multiple sclerosis. And I'm just going to try to use some cases to sort of drive home the point or make this clinically relevant for you. So the first case is a lady she's a 28-year-old woman. She has relapsing remitting MS and she has stable disease. She's on an oral interferon beta 1b and an oral contraceptive, and she wants to get pregnant. I don't know about your patients, but mine often come in with a lot of questions. And here are her questions, and I'm hoping to answer those questions in the next few minutes. Her first question is, what should I do about my medication? Her second is, how is pregnancy going to affect my multiple sclerosis? What are you going to do if I have a relapse during pregnancy? And is it safe for me to breastfeed? So my question to you, we don't have a way, but I'm just going to ask some questions to keep you hopefully thinking. And so which of these statements are true? Pregnancy increases the risk of a MS relapse. Neuroaxial anesthesia should be avoided in MS patients. Postpartum MS patients need to resume their disease-modifying therapy, so breastfeeding is not appropriate. Or the last, pregnancy does not increase MS disability. The answer is actually, pregnancy does not increase MS disability. And I'm going to go over the pregnancy relapse in MS trial, the PRES trial, which clearly showed that the relapse rate 1 year postpartum is the same as the relapse prior to pregnancy. So we can answer her first question as well. We can answer the question is, how's pregnancy going to affect her MS? It's not going to affect her MS. So here are a list of some of the disease modifying agents that are available. And the washout period depends on the half-life of the medication. So for example, and some need almost no half-life. So she's on an interferon. You don't have to, she could stay on the interferon. Once she gets pregnant, she could stop it. Copaxone is, again, a no washout medication. Some providers even continue Copaxone during pregnancy. It's quite safe. But then there's other medications that need to be stopped before pregnancy. So for example, teriflunomide is clearly has significant congenital malformation, and it's a very long half-life. So this is a medicine that most of my colleagues who specialize in multiple sclerosis often don't use in women who are planning some pregnancy because of the long half-life. You have to do this accelerated elimination if you decide to get pregnant on this medicine. And it's the only DMT that the father also has to undergo this elimination. And then there's other medicines like naltizumab, which have at least a 3-month washout. And because they can also have rebound MS things. So these medicines and how to approach pregnancy needs to be very well planned and discussed with these women. So how does the immune system in pregnancy work? And believe me, I am not an immunologist in any way, but basically in this cartoon that I created, there's studies that look at sex hormones and the risk of developing MS suggest that hormonal replacement therapy actually decreases the risk of multiple sclerosis and may decrease disability in MS. So these hypotheses play that low estrogen state actually increase T helper and increase interferons and drive MS, which is an autoimmune disorder aimed predominantly at white matter. Pregnancy is a state of relative immunosuppression. The T suppressor population is increased, and MS is, and because of that, there's an anti-inflammatory and decreased inflammatory response in pregnancy. So this is the PRES trial. So this was a landmark trial in 1998. Before that, women with MS were told that your pregnancy is going to make your MS worse. You should get pregnant. You should avoid pregnancy. And then this trial came out. These looked at patients with relapsing remitting multiple sclerosis. And here's their relapse rate was the year before pregnancy. What happens during pregnancy is the relapse rate actually goes down because, again, it's a time of relative decreased autoinflammation. And then postpartum, you can get a flare, but look at 12 months, the relapse rate is the same as when they started. So this is the trial that says that that pregnancy actually does not affect your MS activity. It also tells us that if you would like to have good disease control before pregnancy, because it's going to make that you're going to make for better reproductive health. During pregnancy, if a patient does have a relapse, again, the relapse rate generally goes down. Certainly, steroids or IVIG can be used. What about so we've answered most of our questions. Our last question was about breastfeeding. So the first thing is, who's at risk? Well, from the PRES trial, we can say we know that there's a slight increase in relapse rate postpartum, but the women who are at risk are those who has poor disease control pre-pregnancy. And for those women who have very poor control and high disease activity, they may need to start their disease-modifying therapies right away. There are some preliminary data looking at the effects of breastfeeding, which are all very positive, and it's exclusive breastfeeding. That is no bottle feeding, all breastfeeding. And a recent meta-analysis looking at MS, women with MS who exclusively breastfed had about 37% lower odds of having a relapse compared to those women who did not exclusively breastfeed. So breastfeeding may in fact be protective. And for those women who have reasonable disease control, this we would recommend that. All right. What about migraine, which is really common, huh? Here's our next case. 23-year-old woman, she has migraine without aura. She's now 8 weeks pregnant, and her migraines had been well controlled with sumatriptan. She's now having her usual headaches with nausea and vomiting several times a week. Okay, so what is true about migraine during pregnancy? A, that often improves by the second trimester. B, are not associated with any pregnancy complications. C, should be treated similarly as migraines outside of pregnancy, or disease, or D, can be treated with one of these our new CGRP antagonists. And the answer is migraines, particularly migraine without aura, which is the more hormonally driven migraine, often improve by the second trimester, and often the second and third trimester, many women will experience no migraine. So 70% of women, particularly those who have migraine without aura, will be improved by the second trimester. This is an old study by Lipton, but it just shows you the stippled line is the prevalence of disease with women, and the solid line is men as age versus migraine prevalence. And as you can see, that the prevalence is 3 times more in women than in men, and that the prevalence rate starts to really be separate around menarche and come back after menopause. And so this is really driven mostly by migraine without aura, which is the less genetically driven migraine. But it's really a disease of women. So what happens during pregnancy? So 60 to 70% of migraine undergo remission, as I told you, particularly likely early in the second trimester. Small amount of women will have their first migraine during pregnancy. More common to have it migraine with aura, which is driven by higher estrogen state. And migraineurs do have an increased risk of pre-eclampsia, small for gestational age infants. So they can have some pregnancy complications. And one of the things I discuss with my women with migraine who are either planning pregnancy or pregnant is the difference between preeclampsia headaches and migraine, so that they are well aware of that and can act and contact their providers quickly. So what about migraine treatment in pregnancy? Well, I think we've talked, planning is the most important thing. So I love seeing young women who are planning pregnancy. And we have to talk to them about medications, which ones we would continue, which ones we would not continue. As I said, this is very important because we really prefer patients to plan rather than come to you pregnant without a plan. I have to tell you that because of the natural history of migraine, and I'll show you in a couple of slides that none of the preventative medicines are perfectly safe. For those two reasons, I usually go to more symptomatic therapy and don't use as much preventative therapy or avoid it if possible. Other things that you can at least think about that can be helpful for migraines depending on drivers. So physical therapy, acupuncture, occipital nerve blocks, all can be helpful depending on the patient's needs. So here are the symptomatic medicines that are available and the breastfeeding lactation risk. So an L1 would be the safest and L4 would be avoid. And as you see, so we talked about nonsteroidals already. Metoclopramide is a very safe medicine. It's also very effective for migraine, not just for the nausea. So it's really effective medicine. You can use it orally, of course, and in the case of status migrainous, you can certainly give it IV. Procomazine is used. Ergots are avoided. Interesting, why does that have magnesium, then it has a D in parentheses? Because I just told you magnesium was a category A. There turns out when high dose magnesium was used for 3 to 5 days as a tocolytic to stop progression of pregnancy, some of those infants had rickets when they were delivered. Triptans, we'll talk about in a minute, but I think they're probably quite safe. And the new kids on the blocks, the dietans and the GPANs, we have no data. So we avoid those since we don't have any information about them. Here are the usual preventative medicines, the level of risk and breastfeeding. So the beta blockers are probably safe, but again, if you don't, since you have a benign disorder that's likely going to get better, many times I'll take my patients off. Of the anti-seizure medicines, certainly valproate and topiramate are to be avoided. And since topiramate is such universally used as a preventative medicine for migraine, you need to make sure you've told your patient about this. Tricyclics and SNRIs, probably safe, but again, if possible, we avoid them. And the CGRP inhibitors, of course, we have no data. We suggest stopping them. The CGRPs are long-acting medicines, so we'd like to stop them several months before pregnancy. I told you I was going to talk a little bit more about triptans. So we have a fair amount of data. So the GlaxoSmithKline, which was a sumatriptan, nortriptan registry, ran for about 13 years. About 900 patients were enrolled. No major congenital malformations were noted. The Norwegian mother and child cohort, there's about 70,000 women, at least 1,500 triptan exposures. Again, no major congenital malformations were noted. There was a small amount of increased bleeding when used towards the time of delivery because of uterine atony. But in general, we consider triptans safe. Obviously, we would not use them if mom has uncontrolled gestational hypertension or preeclampsia. Lactation. So this website, LactMed, is fantastic. You put any medicine in there and it'll come up with the risks and benefits, any concern about breastfeeding. So that's a kind of a great website to go to when you're in the clinic and you say, well, I want to use this medicine. What's the safety? Triptans are safe, non-steroidals are safe, the metoclopramide is safe, and multiple preventative medicines, including beta blockers and tricyclics, are considered safe. So all of these are certainly options depending on your patient. Okay, so we talked a little bit about reproductive health and planning. Let's talk about some pregnancy complications, and because these come up, hopefully not too commonly, but they certainly come up. I talk about ischemic stroke. So here's the case. 28-year-old woman, she's G2P1, she's 30 weeks of gestation, last seen well at 10, and she's found on the ground not speaking or moving her right side at 10:50. On her initial exam, she's mute with left gaze deviation and dense right hemiplegia, and her NIH stroke scale is 15. So there's a number of things that always come up in these situations. So my next question to you is, which of these statements are true around ischemic stroke during pregnancy and the postpartum? Brain MRI, neck and brain MRA are the best imaging modalities. IV TPA should not be used in pregnancy due to fetal risk. Head CT and CTA of neck and brain are the most appropriate imaging modalities. Or the last, the causes of ischemic stroke during pregnancy and postpartum are similar to those outside of pregnancy. Well, the answer is head CT and CTA of neck and brain are the most appropriate imaging. This is a medical emergency. And the woman that I just presented has a significant left middle cerebral artery stroke. She's going to have devastating complications if you don't act quickly. So I think the bottom line is the evaluation and treatment of a stroke should be the same as in the non-pregnant state. So if you have a minor deficit, you may be able to wait and get an MR and MRA. But if you have a significant deficit and you're thinking, because really you should be thinking about TPA and thrombolysis depending on the stroke characteristics. So this always comes up about imaging. We'll talk about that, and then we'll talk about IV TBA and thrombectomy. So there's two separate concerns with radiation. The first is what we call deterministic. That is, there's a threshold. And the picture is an example of a radiation burn. So the threshold is that above a certain radiation dose, you're going to get an effect, okay? And none of our imaging, including 4-vessel arteriogram, at the doses that we, how we do it clinically, are going to give deterministic effects. So that's really not the concern. The concern is this, is stochastic effects. That is effects that there isn't a threshold, and you either have it or you don't. And the probability of getting the effect, it depends on who you are and the dose. So, for example, if you're getting radiation, you either, radiation-induced cancer, you either have it or you don't. And you're more likely to get that if you're a child than if you're an older adult. This is the concern about radiation exposure. So in this lady, she actually wasn't seen here. She was transferred to our hospital, but she had a head CT scan and actually got TPA. And then they did an MRI, and here's the diffusion and the ADC. The diffusion is on the right and ADC is on your left, showing ischemia in the deep middle cerebral territory, the lenticular striate territory. So even though her stroke syndrome is much larger, she only has infarcted her deep territory. And here's her MRA, which showed a cutoff, a left M1 cutoff. Now, at our institution, she would have gotten a CT head and a CTA, which of course takes about 10 minutes to do. And we would have immediately known that she was a candidate for not only TPA, but thrombectomy. So as you can imagine, the TPA was not, pregnancy was an exclusionary criteria, but there's only case reports looking at the effect of TPA in pregnancy. And the bottom line is, as my maternal fetal medicine colleagues tell me again and again, you got to take care of mom, because you don't take care of mom, baby's not going to do well. And here's what you see. Maternal and fetal outcome generally mirror one another. This one death was a complication of arteriography, which we would not be doing now anyway. But basically, TPA should be offered for any pregnant woman who has a stroke that would be appropriate for TPA. And thrombectomy, of course, is even less information. But again, same sorts of things. Maternal outcome and baby's outcome mirror one another. The last point I wanted to make is that the causes for stroke in pregnancy are actually quite diverse. The most common cause for stroke in a tertiary or quaternary hospital, like where I practice, is cardiogenic emboli. But certainly you can have, and then second after that are complications of preeclampsia and eclampsia. But certainly dissection can occur. Coagulopathy, pregnancy is a hypercoagulable state. Strokes related to cerebral venous thrombosis. Reversible cerebral vasoconstriction syndrome is very common. It's an overlap syndrome with preeclampsia. So there's a lot of different causes of stroke, and mechanisms have to be clearly thought through for appropriate treatment. All right, let's talk a little bit about eclampsia. Our next case is a 35-year-old lady. She's G1, P0, and she's 31 and 5/7 weeks of gestation. And she wakes with a very severe headache. She sees visual spots, and about half an hour later, she loses her vision. She develops the worst headache of her life, blacks out. Her blood pressure is 170/120. She's transferred to our hospital. Now, obviously, there's a differential for somebody who comes in like this. But she turns out to have preeclampsia after appropriate imaging and after appropriate evaluation. So my next question to you is, preeclampsia is no longer associated with significant maternal morbidity and mortality. B, caused by abnormal placental implantation. C, not associated with any long-term maternal sequelae, has no radiographic correlate, or E is defined by hypotension and proteinuria. So the answer is caused by abnormal placental implantation. So the cascade of events that actually initiate preeclampsia come on at placental implantation. And even though we don't see any manifestations before 20 weeks, that's when it starts. The definition of preeclampsia does not include the 300 milligrams of proteinuria any longer. It doesn't have to be part of that definition. Okay. Well, here are the red flags for me for headaches in pregnancy. So changes in the headache character or pattern. Headaches with elevated ICP, those are wake-up headaches or headaches caused by cough. New headaches, okay? Headaches with elevated blood pressure. Thunderclap, the headache that comes on maximal onset. And we usually think of that, oh, that's subarachnoid. But you certainly can see thunderclap headaches with reversible cerebral vasoconstriction syndrome, cerebral venous thrombosis, and less commonly in preeclampsia. Obviously, if they have an abnormal neurologic exam, or headaches associated with systemic disorders. So if you have an underlying coagulopathy, which all pregnant women have, or you have a history of cancer or lupus or something like that, you're going to have a lower index to image. This is probably one of, if you don't remember anything from this talk, this one slide is the most helpful about as far as thinking about headaches in pregnancy. So where the woman is during their pregnancy really helps frame their risk. So for example, the first trimester, by far the most common headache is migraine, or at least that's what I see. People tend not to refer tension type headaches to me. New headaches that get worse in the second trimester, that's the time of maximal weight gain. If you're going to develop idiopathic intracranial hypertension or so-called pseudotumor, that's when it happens. Preeclampsia, of course, never happens before 20 weeks, and it's much more common as you get to term. And the real danger period is the postpartum period. So actually, 2/3 of new headaches postpartum are secondary headaches. So that, even though migraine is still the most common, that's the danger period. But where the woman is in pregnancy helps frame what the most, what is this more likely to be primary, or should you really be thinking about secondary headaches, which you're going to think about all the time anyway. The definition is, so preeclampsia is high blood pressure. You have to have 2 separate readings, at least 6 hours apart, with a systolic of 140 and the diastolic 90 or more. And if you think your blood pressure, women's blood pressure is supposed to go down in pregnancy. And it's not really sort of the actual absolute number, it's more the delta. So if you live at a blood pressure, systolic blood pressure of 100, a blood pressure of 130 is actually quite high. The 300 milligrams of proteinuria is no longer required in the definition. Obviously, once you have seizures and change in mental status, we call that's eclampsia. So here's a picture of what happens at placental implantation. I pretty much guarantee you're not going to see many pictures of the uterus in many neurologic talks. But basically what happens is, in a normal pregnancy, which is the cartoon on your far right, the cytotrophoblasts invaginate through the myometrium and make a low capacitance placental maternal fetal unit. That doesn't happen in preeclampsia, as depicted in the middle unit. And that sets up ischemia, and that ischemia causes changes in many hormonal things, particularly F-split, and drives hypertension. So preeclampsia, why do we care? Well, it's associated with significant maternal and fetal morbidity and mortality. So mom's complications, you can have a rupture of placenta, DIC, renal failure, stroke, hemorrhage, death, and as we'll talk about, long-term cardiovascular morbidity and long-term cognitive consequences, decades after delivery. Fetal complications, of course, premature delivery, low birth weight, hypoxic neurologic injury, and death. Here's the sort of a cartoon of what happens with preeclampsia. Certainly, there's genetic factors that play a role. And again, there's abnormal placental implantation. The key thing is there's endothelial damage, and that drives maternal hypertension. And then what happens depends on, and that maternal hypertension is driven by these increased levels of anti-androgenic factors. And what happens depends on the end organ. It's a multi-organ disorder. And in the kidney, if you're getting hypertension, you get proteinuria. In the liver, you can get activation of the coagulation system, and you get hemolytic anemia, elevated liver enzymes, low platelets, the HELP syndrome. And in the brain, you get seizures, visual changes, confusion, and you can get stroke and hemorrhage. And that's driven because really in the posterior circulation, it appears that we have less ability to auto-regulate. And so usually, not always, but usually preeclampsia causes more trouble in the parietal occipital lobe. And it causes this radiographic syndrome called posterior reversible encephalopathy syndrome, which is the radiographic correlate to preeclampsia. And you can see, and of course, headaches, seizures, changes in mental status, and visual disturbance are what we would predict if you have involvement of parietal lobes and occipital lobes. And here's an axial flare image depicting the edema that occurs in PRES in the parietal occipital lobes. Treatment of preeclampsia, first is delivery, is the major problem, a major issue. Then blood pressure control with agents, depending, labetalol is usually used. The only exception, I think, would be if the mom has myasthenia, we wouldn't use a beta blocker. Magnesium sulfate has been clearly shown in clinical trials to prevent progression from preeclampsia to eclampsia. And it's also the treatment of choice for eclamptic seizures. Some of us are old enough to remember this argument between the obstetricians and the neurologists. The neurologists thought, oh, the obstetricians were just, what's wrong with them? Phenytoin was the drug that should be used. And then this landmark trial came out in 1995, published in New England Journal, showing that megsulfate was clearly superior to phenytoin, and that the neurologists were all wet and had been all wet for years. So magnesium sulfate is the treatment of choice for both preeclampsia or eclamptic seizures. So I'm going to end with an example of some postmenopausal health and how to look at stroke differently in women. The last case is a 76-year-old woman who has past medical history of diabetes, and she has new onset AFib. She doesn't smoke. She drinks 1 to 2 alcoholic beverages a week. She never had a TIA or stroke, and she's normotensive. And so the questions, what are some of the sex-specific questions that should be asked, and how do you evaluate her stroke risk? So all of the following are risk factors for stroke in women: atrial fibrillation, gestational hypertension, gestational diabetes, migraine without aura, and preeclampsia. And the answer is the only one that isn't a risk factor is migraine without aura. Migraine with aura is a risk factor for stroke, but not migraine without aura. So, we think of stroke as being much more prevalent in men, and that is true, but it depends on which age strata you're looking at. And so the risk varies across age strata. And in the older age groups, particularly women greater than 85, women have a higher or at least a similar incidence of ischemic stroke as men. And it's the third leading cause of death in women. It depends on your age strata. Pregnancy complications are long-term predictors of stroke risk. And here are the good news about that is that they can be intervened on to decrease risk. So basically, this picture on the right, if you think about where vascular dysfunction can occur, pregnancy is a stressor to your body. And so that population who have pregnancy complications such as gestational hypertension, gestational diabetes, or preeclampsia are more likely to have that be vascular paths later on. So just to give you some sense of this, a woman who has gestational diabetes, she has a 50% risk of developing diabetes within 5 years after pregnancy. So, and as we know, diabetes is a huge risk factor for stroke. Preeclampsia is a risk factor for stroke decades later. And so at least it depends on the severity, but it increases your risk of stroke significantly, 2 to 10-fold, depending on the severity of the preeclampsia. And pregnancy-induced hypertension has an increased risk of women developing hypertension, which is one of the highest risk factors for stroke. Just to show you a couple of retrospective trials. So preeclampsia and stroke risk, these are, again, retrospective, mostly cohort trials, and odds ratio of stroke. And you can see this odds ratio of stroke is about at least 2 or sometimes 3-fold in this last cohort, which had very severe preeclampsia, 10 times higher. And so here are risk factors that we should be asking our women about and that we can intervene on before they have their stroke. Atrial fibrillation is an independent predictor of stroke in women. And those of you who use the CHAS-VASc score to quantitate risk for in AFib, you get an extra point if you're a woman. And the reason is that because of trials, this is particularly true for women greater than 75. There's a big trial that was it was out of Sweden, actually, looking at about the risk of stroke in about 100,000 patients with non-valvular AFib. And the incident risk of ischemic stroke was in women was 6.2% and men 4.2%. It's not clear why that women have higher risk, but you should have a much, that's why you get an extra point and more likely to anticoagulate a woman than a man. Because of these differences in stroke risk factors, this guidelines for prevention of stroke in women came out in were published by the American Heart Association. It's a great piece of work and very, very thorough. So I encourage you to look at that. All right, so I'm going to end with, we talked about some reproductive health and pregnancy concerns and used MS and migraine as an example. We talked about pregnancy, some things that can occur in pregnancy, including stroke and eclampsia. And then we talked about postmenopausal health using stroke and stroke risk factors as an example. Again, just different ways to think about how women vary from men and how you need to think about neurologic disorders with a specific lens. I hope I've given you some insight, more than this faculty here in an academic hospital stating the obvious to the students. So hopefully I have given you some information that's helpful. I'm going to stop share and hopefully answer any questions that anyone has.
Okay, thank you, Dr. O'Neill, for this incredible, informative talk. Now we can open it up for questions. Please feel free to type any questions you have for Dr. O'Neill in the comment box, the live chat, also known as on YouTube, so that I could forward these questions to her for her to answer. Okay, our first question is, this is a question about migraines. For the timing on medication change when planning pregnancy, what is the best way to approach this? Do you stop the medication when pregnancy is decided and the patient is trying to conceive, or do you implement the changes at the time when pregnancy is confirmed?
Okay, great question. Well, the first thing is depends on the medication and the half-life, right? So let's say you have a woman who's on topiramate and they're planning pregnancy. Topiramate has a short half-life, so you can stop it pretty quickly and it'll be out of your system, you know, in 2 or 3 days. But if you've been maintained on that for a long time for migraine prevention, you might want to taper it. And so it's not really related so much to the half-life of the medicine, but the fact that if you'd like to taper it and make sure that you have the migraines fairly well controlled, hopefully on just symptomatic medicines before pregnancy. If you have a longer medicine, like say some of our CGRP inhibitors, those have to be stopped. Those have long half-lives, so you want to stop those about 3 months before conception.
And our second question is, how do you approach to the mother that you are offering TPA? I found this very challenging as a resident when I was discussing the possibilities. She does not appreciate the uncertainty of side effects. How do you suggest to direct the patient on making a decision?
Very straightforward. You tell her that what we know about stroke and pregnancy is that that we should guide our treatment on the stroke severity. So if a patient has a minor stroke, of course, you're not going to offer her thrombolytic therapy or thrombectomy. But if they have a major stroke, you know, this is a neurologic emergency. And I think you can share the data that we have is that it is safe for baby. And definitely, particularly thrombectomy is a very powerful you know, it's powerful tool. You know, the number needed to treat for thrombectomy is like 1 in 3. I mean, it's really powerful. So if someone has a devastating stroke, they should be offered the same modalities as anybody else in stroke who has a stroke. And that's the consensus with all stroke neurology.
Perfect. And our next question is, what are the challenges to treatment when treating women with neurological disease? And this is a follow-up question, I believe. Do you think being a woman is a risk factor for medication non-adherence and less follow-up risk, especially in elderly population, as they are often the caregivers?
Oh, well, it's a risk factor for non-adherence in pregnancy and in older adults. So I think that the challenges are to weigh the risks and benefits of treating the woman versus not treating. So we'll talk about pregnancy. For example, using epilepsy. We didn't talk about epilepsy, but epilepsy, epilepsy can be a very severe disease, and you need to talk about a lot of things with around pregnancy and epilepsy. And what you'd like to have is them to be adherent to anti-seizure regimen that is safe during pregnancy. Many women will stop their anti-seizure medicines because they think they shouldn't be on them. But, seizures can be deadly. SUDEP is not, sudden unexplained death in epilepsy is not, it's a real phenomenon. Older people can have non-adherence for many reasons. I didn't really specifically talk about Alzheimer's disease, but the burden is higher on women for two things. One is women are often the caregivers, as that may cause them to neglect their health. And then women, because they live longer, have a higher burden of cognitive things as well. So I think there's a lot of challenges, and you have to think about a lot of things. Bone health and many of our medications is important. Again, you have to think about where the woman is in their life and what are how the implications of the medicine and her neurologic disorders intersect. So I think it can be very challenging, but it's also very rewarding to treat these people.
Thank you. So looking at the chat, I don't see any newer questions. So as we're approaching towards the end of our talk, I'd like to thank everyone for attending our monthly medical forum talk. For this month's talk, we had Dr. Mary Angela O'Neill over to give us a talk regarding women's health and neurology. Before you leave, please make sure to take our 3 questions long post-talk questionnaire that will test your knowledge of today's topic. It will take no more than a couple of minutes of your time. Again, thank you all for coming and have a great rest of your day.
Thank you.